Hello, my name is Dr. Robert Odell. I'm an anesthesiologist and a pain management physician here in Las Vegas, and I'd like to talk a little bit about a unique treatment for neuropathies that we're doing here at my clinic. As you probably know, neuropathy is quite prevalent. It affects about 3 to 8.2% of the population, and the prevalence probably increases with age. The current state of treatment of neuropathy is not very good. The 50-50 rule states that if a drug works on 50% of the people and gets them 50% better, it is acceptable. As you know, Neurontin and gabapentin and Lyrica, or pregabalin, are the only two real good treatments for neuropathy, and their treatment profile includes side effects, patients feeling like zombies, things like that. I'd like to define neuropathy as pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. This is according to Treed. The causes of neuropathy, as you know, include diabetes, viral infections, including postherpetic neuralgia, diabetes, and PHN being the two greatest causes of neuropathy, AIDS or HIV, chemical insults, mechanical insults like disc disease for neuropathies, CRPS, central neuropathies from strokes, spine surgery, and amputation. We'd like to focus specifically on diabetic neuropathy because this is the #1 cause. The problem with diabetic neuropathy, as you know, is patients who have loss of peripheral sensation often will injure their foot, and this can lead to amputation. The cost of an amputation in the first year ranges between $120,000 and $150,000. My colleague, Dr. Anthony Ricciardi, a podiatrist in town, and I have started a diabetic neuropathy and limb preservation center, where our goal is to prevent just this, namely through treating the neuropathy initially, and if that doesn't work, utilizing some of his podiatric skills to prevent the amputation. Now, our treatment is new and unique, and it's a very, very safe treatment. We use physics instead of chemistry. We're utilizing electricity from a machine, electroanalgesia machine like this, to treat the cells. We're signaling the cells, we're not smothering them. This is a paradigm shift that we hope takes place over the next years in medicine. Rather than treating people with chemicals, we treat them with physics. I would like to talk about how we treat these. We utilize the electroanalgesia treatments along with peripheral injections. The first aspect of this is the peripheral injection. In general, for diabetic neuropathy and other lower extremity neuropathies, it involves a lower extremity injection just above the ankle. We use a low dose and low volume of local anesthetic. The local anesthetic is allowed to move into the nerve cells by anapheresis according to the laws of physics when this electrical device is applied just after the block. We go ahead and do the block, both ankles. We do them twice a week, and we actually allow patients to drive home. The reason we do this is because the dosage is low and the volume is low. We are not doing a surgical block. We then apply the machine treatment to the patient after this. This device is way more sophisticated than TENS, although there are TENS frequencies built into it. I can't get into all the physics of the device. It's beyond the scope of this talk. But basically, what we will do will stimulate the neurons. We can activate the pain-suppressing neuromodulators. We actually are giving an electrical modality, which is a pharmaceutical strength. In other words, instead of giving a pill, we're utilizing electricity. There's absolutely no risk. I tell my patients that the only way I can harm them with this machine is if I drop it on their head. The injections themselves, you can imagine with diabetics, you have to be very careful of their feet. We inject the patients in different spots up and down the leg, and we watch their feet like hawks to make sure that there's no lesions as a result of the injection. And this is very, very rare. Now, these complex waveforms are designed to reduce inflammation. I have a paper in the latest issue in November, December of Pain Physician, which describes some of these biochemical mechanisms. We increase the blood flow via blocking the sympathetic nervous system. We increase cyclic AMP into the cell. That second messenger is good for cell health, and when I say cell here, I'm referring to the nerve cell as well as the muscle cell. The nerves and the muscles have the lowest resistance, as I'll allude to in a minute. We're enhancing metabolism and the diffusion of cell waste products away. We're also blocking the neuron. This device actually blocks the nerve open. All of the sodium, potassium, calcium channels are opening and closing in equilibrium, and it allows the cell to freely metabolize. This is healing. The chemical block clamps down. You can't do surgery with electric nerve block. With a chemical block, you can. Somehow the combination enhances the effects of both, and you get excellent results. Now, the final thing that this will do will be repair, stabilization of the cell membranes, both chemical, both muscular and neuron, which is so important for healing. Now, why does this work so well? Well, again, the selective resistance of these tissues, the nerves, 1,000 ohms, blood, 1.6 K ohms, and the muscle, 5,000 ohms. Because of this, the electricity tends to go to the muscles and to the nerves. 5 times the electricity will go to the nerves than to the muscles. By example, by contrast, the bones have a resistance of 160,000 ohms. If you have a pipe that's 160,000 centimeters wide in diameter versus 1 centimeter, where is the water going to go? So what this does is the medicine, the local anesthetic, is anaphoresed or moved into the cells, mostly the nerve cells, and then secondly the muscle cells. Keep in mind that the greatest source of pain is the muscles and the nerves. And we know in neuropathy that the nerves are the problem. This also, by the way, works in inflammatory problems in the foot. I get referrals from local podiatrists all the time who have done surgery on patients who have some inflammatory condition, and it works very well. One of our patients, who was actually a female jet mechanic here in Las Vegas, was referred to me. She could not wear steel-toed shoes because of an inflammation from twice-operated plantar fasciitis. We injected the ankle immediately. We injected the plantar fasciitis. We waited about 5 minutes so the injection wouldn't hurt as much. And after 5 or 6 injections over about a 3 or 4 week period, she was pain-free and she was actually able to go back to work. Now, what are the other things that this does? We depolarize the nerve cells, as I mentioned. We normalize the cell activities and allows the cells to heal themselves. The key thing here is that the combination of the local anesthetic and the physics provided by this fancy electrical current will in fact allow the body to heal itself. The body does a much better job of healing than we as physicians do. We're just allowing the cells through signaling to heal itself. Again, I cannot overemphasize how safe this treatment is. In summary, we have increased effectiveness, we have way decreased risk, we have a decrease in side effects. How many patients have described to you what kind of zombies they are when they take Neurontin and Lyrica? We feel we can decrease the costs over time because if a patient is on these drugs, or they might even be on narcotics, the cost of these will be eliminated essentially. We have reason to believe, although there's no published literature yet, that this treatment will last for a long, long time. We also get a greater longevity of benefits, and the mechanism of action is multiple and complex, but these mechanisms have a very solid basis in citations through the literature dating back to the 20th century. If you look at our paper, you will see that the citations go back to the 40s, 50s, and 60s. But because it's physics, it's just as valid as citations of the last few years. Now, some other additional considerations, indications would include fibromyalgia. There have been groups that have treated fibromyalgia by just treating the area of greatest pain, for example, the low back. Then we use what we call a metabolic sweep to treat the whole entire body. After about a week, the fibro patients generally have a much easier time of sleeping, and they start to do very, very well. Myofascial pain, trigger points, cervical sprain strain, whiplash, lumbosacral sprain and strain, radicular pain. I am an interventional pain management specialist, and I will do an epidural in the back. Go ahead and treat the patient with the electrodes, these vasopulse electrodes here that go down the leg in the distribution of the radiculopathy, and this works, in my opinion, way better than steroids. We actually can do more than the 3 blocks because we're not using steroids. The anti-inflammatory effect is happening right here. We treated RSD and also other peripheral neuropathies. Some other uses include with neuraxial blocks to enhance the effectiveness of epidurals. As I mentioned, we've used this technique with people with failed spine fusion syndrome. It has not worked on everybody. It has worked on some of the patients. Many of these patients have no other options. Many of my patients that are sent to me, really, I'm a clinic of last resort, and we've been amazed with some of the results that we have seen. I'd like to refer you to the anti-inflammatory paper, as I mentioned. There's also a paper in Practical Pain Management in 2006, which is an overview of the electromedical treatment with some case reports. One of our hopes for the future is to form some special interest group and get multi-center studies going to validate this treatment, which I have seen works so very, very well. I thank you for your interest, and if any of you would like to give me a call, I can be reached at 702-257-7246 in Las Vegas. We're on California time. And thanks very much for listening.